Okay, as we were saying, this is the European guidelines for the management of valvular heart disease. We are not going to cover the whole valvular heart disease because it's a very long presentation. We are going to cover first the aortic valve today and the baseline for this valvular heart disease. As you know, you have to always mention the classes of recommendations. I think you all know this one, the class 1 recommendation. This is it's highly recommended or indicated. The class 2, it's there is conflicting evidence, but the opinion is going towards doing this, especially the 2A should be considered, while the 2B it may be considered. The class 3 is always not recommended. Okay, the level of evidence A, B, and C, you know that it is when you have say that this is the level of evidence A, this is derived from multi-randomized clinical trials or meta-analysis. The level of evidence B, it is data derived from a single randomized clinical trial or large non-randomized studies. Level of evidence C, there is consensus of opinion of the experts and or small studies, retrospective studies, registries, but you don't have randomized clinical trials. Okay, when you are going to talk about valvular heart disease, we should always mention this. The European, they mentioned requirements for a heart valve center. This is important. Why? Because when you have a heart valve center, you have a lot of specialties in one place. It's not only a cardiologist and not only a cardiac surgeon. You have, as we have looked in the cases that we mentioned in the conference today, you have to see a lot of imaging. You have to have a good infection disease doctor, especially thinking about valvular heart disease, because we have a lot of infective endocarditis in our third world country. We have to have a lot of imaging modalities available in the place, and we are going to mention them, all of them. We are going to have, you should have a very expert anesthesiologist in cardiac procedures, especially in high risk patients. So if you have this teamwork, then you can treat valvular heart disease in a correct way. And you have to have a heart team discussion about each patient and the experience. And we are going to mention this in different ways now. Okay, you know the multimodality imaging, including the echo, the CT, the CMR, the nuclear medicine, and which give expertise guidance on surgical intervention procedure. As you have seen the patient from today with the mitral valve repair and the suture in the coronary. Okay, so the patient-centered evaluation of intervention for the valvular heart disease, it's a network. The network includes all what we have mentioned. First of all, we depend on our department on clinical. You have to have a good clinical expertise in order to be able to manage the patient in a good way. Because if you miss something from the clinical from the start, then you are going to have a problem. So, if you want to learn in a good way, you have to start by learning all the clinical skills. When you meet a patient, you know how to examine him right, you know how to evaluate his valvular heart disease by the stethoscope from the start. After this, you do an X-ray, you do an ECG as an additive clinical tools. You use them, then you go for the echo. Sometimes people, a lot of doctors, they don't use these clinical skills from the start. We used to do it. When you have an aortic valve disease, you start by examining, by hearing the aortic valve, you find all the peripheral signs of the aortic rigor and something like that. So you have to have all this clinical. Okay? Then you go advanced to the echo, more advanced to the CT and CMR, and you should evaluate the patient from the general condition to evaluate the decision. If you have a patient with severe heart failure and the ventricle is failing and he has multi-organ affection, then you should consider, should I do anything to this patient? Is he going to benefit? What is the life expectancy after surgery? If you evaluate this in the right way, some people, not all patients are going to be sent to surgery. Some patients are going to be left for medical treatment. But after we talk to the patient and the residents and tell them the risks and the benefits and how frail he is, you should consider this. Okay? And that's what he said about the heart team decision. Okay, now we are going, this was from the European, now we are going to shift to the American guidelines in order. First, evaluation of a patient with known or suspected valvular heart disease. What you are going to do, sometimes this patient is referred to you from another department. This patient was doing any checkup and they found in the echocardiography this. So the American put it, the transthoracic echo as a start because they found that a lot of patients have been discovered to have valvular heart disease accidentally during an echocardiogram. So sometimes, so they put the echo as the first test, and they went to the way we do it in our department: history, physical examination, and ECG. The history and physical examination from them and ECG, it's supposed that we know if this patient has any chamber enlargement, the patient is symptomatic or asymptomatic. That's what we should know from this before going to intervention to this valvular disease. Then we do the X-ray or the transthoracic echo and the TE and the CMR. Evaluation of the left ventricle and the right ventricle, which is very important. The right ventricle is always not considered during our evaluation of patients for surgery, but it's very important. The surgeons taught us that they think about the right ventricle in all cardiac surgeries more importantly for them than the left ventricle. Why? Because when you have a patient likely with severe COPD, they sometimes they do a successful procedure regarding the mitral valve, regarding the aortic valve, but they can't get the patient off the bypass machine because this right ventricle is failing or has failed. So you have to evaluate the right ventricle in a good way, in the right way. Okay. You know, when you have department like us, which is known for caring for infections like endocarditis, you should have a PET CT. Sometimes PET aids in determination of active infection or inflammation. I have seen a patient in the United States with active infection, and the only part of his with endocarditis, and the only part of his history that he has implanted a stent 6 months ago. So after evaluating with the echo, with everything, the patient doesn't have any source of infection. The echo appears normal, nothing, but the patient has all the features of endocarditis, from the fever, from the laboratory parameters of endocarditis. So they did him a PET CT, and the PET showed us a very nice picture of an abscess around the site of the stent. So they did coronary angiography, and it was seen an abscess around the stent. So you need to have PET if you are dealing with infection. PET CT is very important for this. Stress testing and catheterization. We have stress testing. It's important in valvular disease because it gives us how actively this patient can go. And in some patients, the decision is based about how much exercise can he do. Sometimes you defer the surgery, you postpone the surgery if the patient is exercise capacity is good. In valvular heart disease at young age, sometimes you defer. And in old age, sometimes you need to do it to show if this patient will benefit from this or not. Okay. And the cardiac catheterization. We need to know, and it is very important to know, to read from the cardiac catheter books. What are you going to find in every valvular heart disease catheterization? Every valvular heart disease has a specific way of determining catheter. You have to know what's the endoscolic pressure in aortic rigor, what's expected in aortic stenosis, what's expected the left atrial pressure. So when we were young, we used to do full cardiac catheter, left and right sided, before going to surgery. That was our practice. Now we have non-invasive tools, but sometimes you need these tools. Okay. Evaluation of patients with known biomarkers. Uh, Now we have the pro-BNP, which tell us a lot of things about the ventricular function, how the heart failure is going, and the assessment of the heart failure. And the strain echo helps us. The intrinsic performance, well, CMR, gives us an important ideas about the fibrosis the patient has. The fibrosis affects the decision. Okay. Stress testing, we have a lot of stress testing with different parameters. We use in each case a different one. Okay, and what is very important score is the frailty score. Yes, that's very important in old age because when you have an elderly with severe valvular affection, you have to evaluate the center experience with the surgeon to know if this patient can make it through surgery or not. He can have successful surgery, but he can die from a lot of things if this patient has different organ affection, if this patient has hepatic affection, if this patient has cirrhosis, if this patient has renal impairment. You have to think about this. If this patient is Parkinsonian, it's different if this patient has old strokes. The incidence of stroke in this patient during surgery. Yesterday, I just seen a patient who went an old age who went to surgery. He needed the surgery, but he ended up with severe stroke post-operatively. So you need to think about the whole picture of the patient to take a good decision. Evaluation of patients with known or suspected valvular heart disease, we have to now, before sending any patient to do any valvular heart disease, this patient should meet a dentist. We shouldn't wait until the complication. We shouldn't wait about till the complication happens of endocarditis to examine his teeth. Please, if you are going to send any patient to valvular heart disease, valve replacement, please send him to a dentist first. Treat his teeth, then send him to surgery because we have seen a lot of prosthetic valve endocarditis regarding this. Yes, okay. The CT coronary angiogram is important to evaluate the coronaries before valvular heart disease. Like the patient which was presented the day of the conference, the patient is 42 years old. By the guidelines, he should have had a coronary angiography or CT angiography for the coronaries before doing the mitral valve repair which was done. So we wouldn't have been in the dilemma of diagnosing if he has, if this was only suture affected or this was arthrosis. Have you attended the conference today? Yes. Okay. The CT peripheral, it's important to evaluate part of the TAVI protocol, as you know, is to evaluate the femoral arteries, the iliac arteries, and the aorta from below. Because if the patient has blocked iliacs, you can deliver an aortic valve. So part of the TAVI protocol is to evaluate and to determine where to puncture. So now in the TAVI we use ultrasound duplex to determine where to put, where to insert, because you need a wide caliber away from plex. Otherwise, you do a TAVI protocol and you have a very nice dissection down that can need stenting or can need surgery. So it's better to evaluate the peripheral arteries thoroughly before doing this procedure. The cardiac CT is important for evaluation of TAVI and something like this. Okay, the staging. The American put a nice way of doing the staging. Stage A is the patient who is at risk. This patient is at risk of developing some in this valve. Some, like for example, if you have aortic atherosclerosis, aortic sclerosis, this patient is at risk of developing aortic stenosis because he has aortic sclerosis. This is type A. B is the progressive. Progressive is the mild to moderate patients who already have the valvular affection. When you see a patient with mild aortic stenosis, mild aortic regurg, this is class B, and this is progressive. The class C is the severe type of the valvular affection, but without symptoms, the severe asymptomatic type. And we find this commonly in the aortic regurgitation. You will meet a lot of aortic regurgitation with severe aortic regurgitation, but the patient is totally asymptomatic. And we reclassify them into subtypes. C1 is asymptomatic with severe valvular loop. The LV and RV are compensated, and the class C2 with decompensated left ventricle, right ventricle. Okay, and the stage D is the symptomatic severe, and this patient is indicated most probably for surgery. Mean view. C2, we are going to discuss for each valve what we are going to do. It's different. Most probably the C2 needs intervention. لا not symptoms. احنا اتفقنا من الاول ان this is asymptomatic severe. This is asymptomatic. اول حاجه class C is asymptomatic. class D ده symptomatic but and severe, فده مش بنتكلم فيه. لكن class C symptomatic severe, but the echo shows that this LV has been affected or this RV has been affected, so we need to intervene in order not to make it worse or not to make this patient wait till he becomes or inoperable. Sometimes you meet people who are inoperable because they have passed the stage where you can operate on them. Sometimes, and yeah, this is what we find in people. Diagnose and follow up. Okay, this is very important, and this is not applicable in Egypt. How, which is a very common question asked by the patients. How frequent should I do an echocardiogram when I have a valvular heart disease? In Egypt, most probably the patient who has mild mitral regurgitation does an echo every 3 months. He comes to you, he tells you, I have a bad valve. This is what he says. I have a bad valve. I have affected. I have seen a lot of them. I just done echo 3 months ago. I need to check my echo. So you have to reassure the patient and tell him you have mild aortic regurgitation. You need echo every 3 to 5 years, not every 3 months. Okay, unless when you have this is stage B. Unless every 1 to 2 years, if the patient has moderate and you are suspecting that it will progress, so you make it yearly. If this you are suspecting that this is a progressive course, so you make it yearly. And this is important for all of the valves because this, and you have to reassure the patient. You have to tell him, no, you don't need this. You are well. I usually, in my practice, when I see a patient with mitral valve prolapse, I don't tell them your mitral valve prolapse because when a non-medical patient knows that he has a valvular heart disease, some people, they get very annoyed and they think they are going to die. So don't tell people you have mitral valve prolapse. And that the patient has mitral valve prolapse, which is complicated. Moderate regurgitation, the patient has PVC, the patient is already complaining of significant symptoms, not just stitching pains, which are told by most of the young generation. When you get a young generation doing echo with stitching pains and you find mitral valve prolapse, you tell them you are fine. Even if you write it in the report, you tell him you are fine. And when he asks you about the mitral valve prolapse, you tell him this is a normal variation in 20% of the people, of the population. So that the person gets calm. Okay. In the severe asymptomatic stage C1, which you were asking about, we do every 6 to 12 months, unless the patient is mitral stenosis. Why? Because mitral stenosis progression is less than other valves. The other valve, mitral regurgitation, aortic stenosis, the progression of the disease is faster. So in mitral stenosis, you can wait 2 years unless the patient gets symptoms. Okay. The basic principles of medical therapy, that's an important one. And this is important in our country. In patients with rheumatic heart disease, secondary prevention of rheumatic fever is indicated. It's indicated. You have to have secondary prevention. What is the second prevention? The long-acting penicillin is the drug of choice. The 1.2 million every 4 months, and in high-risk patients every 4 weeks or every 3 weeks in high-risk patients. Okay. If the patient can tolerate the injection, penicillin B or sulfa, if he is allergic to penicillin sulfa, then the macrolide group is indicated. But patients should have this. For how long? The, the American guidelines say for 10 years or until the patient reaches the age of 40. No, in patients with carditis and residual heart disease, he still have valvular heart disease. If the patient had carditis before, but no residual disease, which is unlikely to find. This group is unlikely to find. You can find the first group and the third group, the rheumatic fever without carditis. But this group is rarely. I have rarely seen a patient who had carditis, but with no residual valvular disease. Most probably you will find the patient with carditis and residual valvular disease. So this, it should be given to the age of 40, and sometimes more than this. Some people recommend more than this, especially in countries like us. I have seen. He had a history of carditis. He had, well, it's just rheumatic activity of carditis. Yes, respect this. Sometimes you find what you are saying in a patient who is asymptomatic. No, that's not important. Uh, Evaluating a patient by patient is important. Okay, I have seen a lot of patients with history of rheumatic fever, with mild affection, like you said, but they had carditis, and they still take the long-acting penicillin till the age of 70 and 80. And when you tell them you don't need this at that age, they tell you, when I stop taking the long-acting penicillin, my joints ache. The patients who have rheumatic heart disease, they all of the rheumatic carditis, they passed by the stage of rheumatic arthritis. And the patient who passed by the stage of rheumatic arthritis, they benefit for the arthritis even at older age from the long-acting penicillin. I know a lot of patients who told me this. It's told by patients, I want to have the long-acting penicillin because in the winter especially, my joints ache if I don't take it. Okay? Long-acting penicillin is magic. Yes. Yes. High risk patients. They select patients, they see that يعني ما احنا اغلبنا most probably you have patients with low socioeconomic level who doesn't take antibiotics regularly, who I think especially if he has moderate affection, it's better to take it. I recommend this, but some people, a lot of people hate the injection. It's a bad injection, especially. Have you given a long-acting penicillin injection? No. The, 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 the solute in the injection, it's very thick. You have to shake it a lot, and if you leave it for 1 minute, it gets like powder. You can't get it out of the syringe. You have to use a 20 syringe. It's a tough injection, and it hurts. Oh, this is our department, the infective endocarditis prophylaxis. This should be considered in all patients. And talking about infective endocarditis prophylaxis, we have a notice that I have seen in the United Kingdom when I was in England. They had, when I was there, it was around 2007, they were changing the guidelines at that time of the infective endocarditis, and they reduced a lot of lesions. Before 2006 and 7 and 8, they used to give prophylaxis endocarditis to a wide range of lesions, like the ASD, the BSDs, something like this. And anyone with congenital heart disease, minimal congenital, they used mitral valve flaps, anything they were giving him long. So they decreased this. And I was in England, and at that time, we were passing by a patient which is he had something very mild, and I found that the consultant wrote on his ticket that he has chest infection and wrote him prophylaxis against endocarditis, which wasn't the case. And I asked the man, "Why are you doing this?" He told me, "We are not Cleveland Clinic, we are the UK." So you have to know where the guidelines has been put and where can it be applied. So we are not the US, we are not the UK, we are Egypt. You give prophylaxis to normal patients. Huh? You have to give anybody with prosthetic valve, you have to respect this. Anybody with any lesion, you have to respect it. Follow the guidelines, not always. Okay? You have to study this first for the exam. Okay? Which is the way. Okay. I can. These slides are from the American Heart Association. You can download it from the. It's free on the net. These are not my slides. The American Heart Association, as you can see. This is very important. Anticoagulation for atrial fibrillation patients with valvular heart disease. For patients with atrial fibrillation and native valvular heart disease, except the rheumatic mitral stenosis, all the guidelines are going towards NOAC or oral anticoagulants, not warfarin, except the moderate to severe mitral stenosis and the prosthetic valve, or a patient of high risk for embolization on NOACs. They go for warfarin, okay, with no evidence. This is class 1. Class 2A, for patients with new onset atrial fibrillation with less than 3 months after surgical or transcatheter bioprothesis. Here we are talking about a bioprothesis, valve replacement, and population with VAKA is reasonable for sometimes for 3 months and sometimes they stop it. But in patients with mechanical heart valves, we don't have an option except the VKA. Okay. So it's easy to revise this. Rheumatic mitral stenosis, VKA, unless it's mild. All natives, it's NOAC, bioprothesis with new onset atrial fibrillation, VKA. Sometimes some people give it NOAC. Okay. After 3 months, the first 3 months it's better to have warfarin. No, in bioprosthetic, especially if you don't have an evidence of, and this is going to be a long-standing atrial fibrillation, and sometimes when you have a long-standing atrial fibrillation with a bioprothesis, you can give no one. Evaluation of surgical intervention, that's very important. For patients with valvular heart disease, whom intervention is going to individual risk should be calculated for specific surgical or transcatheter procedure using online tools like the scores of the Fertility scores, which we have mentioned, and should be decision making, as you said. Okay, you know the scores, the STS score, surgical score, or Fertility score, and the procedure specific implantation. Every one of them you have to look for this, especially if you have a multi-organ affection, more than 3 organs or more than 2 indices in the Fertility score, and the predicted risk of death. If you have a patient with a high risk reaching 80 to 90%, you have to tell him if you are going to surgery, the patient is more likely to die than more likely to live. Sometimes this is our last option, and sometimes, but you have to tell him the truth. And telling the people the truth is very important in high risk individuals. Very important. Okay. Surgical risk. That's very important to have examples for major organ system compromise, which was mentioned in this one, the organ system pericardiac or major other. This should be known. What is the major? How can you define this? The severe LV systolic function is the major organ affection. The severe RV dysfunction is the major organ affection. The pulmonary hypertension is the major organ affection. The kidney dysfunction is the major organ affection. And the first three I mentioned are considered separate. You have severely left ventricular impairment and severely RV impairment. There are two factors, not one. And pulmonary hypertension is the third one. This increases the risk. And kidney dysfunction, pulmonary dysfunction, the patient is COPD and they have problem, pulmonary fibrosis and something like that. Central nervous system dysfunction in the form of dementia, Alzheimer's disease, Parkinson's, cerebrovascular strokes before persistent physical limitation. You have to think about this. If the patient is already moving with something on a wheelchair, something like this, he doesn't exercise. Does he need the surgery? Does he need to change his valves? Or you have something like continuous pulmonary edema, something like this. You should consider not telling patient who is disabled that he needs cardiac surgery. The gastrointestinal dysfunction like the Crohn's disease, the ulcerative colitis, nutritional impairment, serum albumin less than 3, cancer, active malignancy. I have seen patients with active malignancy who were referred to me to discuss if he is fit for cardiac surgery before going for malignancy removal. You have to evaluate this malignancy and the life expectancy of this malignancy. Is it spread or not? Is he in old age? Is he did he do a PET CT and you find where the metastases are? What is the life expectancy of this malignancy before going for surgery, even TAVI? You have to think about this. The liver dysfunction. And importantly, the most important factor in evaluating liver dysfunction is the baseline INR without VKA and without NOAC. Because I have seen some patients who got elevated INR with NOAC. Although in the book it's sometimes written and sometimes they negate this, but I have seen it. You find somebody with a baseline of INR of 1 and you give him new oral anticoagulants and he gets you an INR of 2. You will see this. It's not written in all books, but you will see it. So you have to have a baseline INR before giving any anticoagulation. If the patient have an INR of 1.8, this patient is very high risk for surgery. And if the patient has liver cirrhosis, you should check his esophageal varices. Does he have esophageal varices? And there's examples of procedure-specific implementations, like the heavily calcified porcelain aorta. Some surgeons, when they see CT of a patient with a porcelain aorta and the patient has severe aortic stenosis, they tell you, I'm not going to operate about this patient. I can take sutures in this aorta. You go for that. They told me, expert surgeons, that the aorta breaks as if you are breaking a piece of stone. So, if you are experienced enough, you don't go into this, and you don't have anything to do. Special. Sometimes they do aortic root change, but sometimes you don't have an area which is not porcelain to put the graft in it. You know what I mean? Sometimes you have a short segment of calcification, sometimes the whole aorta is calcified. No, this patient shouldn't be touched by surgery. It should be going for TAVI. Okay. This is an example of procedure-specific risks for intervention not incorporated into existing risk scores. This is important. The SAVR, the surgical aortic valve replacement versus the TAVI. Technical or anatomic. Okay. Prior mediastinal radiation. If this patient has prior mediastinal radiation from any cancer or anything like this, or the patient has aortoiliac occlusive disease before, this is in favor of what and this is in favor of what. You don't like to open a sternum in a patient with prior radiation. The ascending aorta calcification, the porcelain which mentioned, the aortic arch atherosclerosis, the severe mitral regurgitation tricuspid, the patient has other valvular lesions, the low-lying coronary arteries, this is known in the CT, the valve morphology, bicuspid or unicuspid aortic valve. It can be done off-label, but it's not the guidelines indicated in TAVI still. Extensive LV outflow tract calcification. Okay. And in the mitral valve repair or mitral or H2H, the same problem. Prior stenotomy, multi-valve disease, prior mediastinal radiation, ascending aortic calcification, valve morphology taken, perforations, clefts, endocarditis. This is in favor of surgery. They open. هم مش عارفين يعملوا calculation كويس and the patient most probably غالبا it's unlikely to find a porcelain aorta without severe aortic stenosis. غالبا you will do both. Severe comorbidities, severe COPD. Good surgeons always ask for pulmonary function tests in the patient with COPD. It should be done in most of the patients with prior to surgery. Pulmonary hypertension, severe right ventricular dysfunction. I have seen a patient recently who had valvular disease and she did successful surgery, but they couldn't get her off the machine because of the severe RV dysfunction. They say the surgeon say that you find a ballooning RV, hepatic dysfunction and the frailty. Patient with severe COPD on home oxygen therapy. This patient, I don't think that this patient should be touched by any means. He already has a problem. Severe pulmonary hypertension, severe RV dysfunction, hepatic dysfunction, severe, the same. This is the same. Okay. Examples of procedure-specific risk factors for interventions not incorporated into existing risk scores. The ST score more than 15, the life expectancy is less than 1 year. Poor candidate for rehabilitation. Some patients can't do rehabilitation. These patients shouldn't go for surgery. If the ST score is more than 15, life expectancy is less than 1 year, and poor candidate is also not candidate. Okay, the same applies to the mitral valve. Okay, this is a very important mortality rate that should be told to patient, and this is based on very high surgical centers. So most probably we have a higher risk than these. They say that aortic and mitral valve replacement, the mortality rate is 9% during surgery. This is in Cleveland Clinic. Okay, the aortic valve alone is 2.2. The mitral and CABG is 5%. The mitral and CABG, so either repair or replacement, it's 9. It's nearly 10%. You have to tell him this. And also, in high-risk coronary artery disease patient, you have to tell him that, especially if he has good distal flow and the patient is good CABG, you have to tell him that the mortality rate in CABG in well-organized centers is less than the PCI of left main and diffuse coronary artery disease. You have to tell the patient this. Otherwise, you are leading the patient towards multivessel PCI. You have to be honest with them. This is the multidisciplinary heart team and heart valve centers. Okay, patient with valvular heart disease should be evaluated by multidisciplinary, as we said, when intervened. Consultation with the referrer or primary or comprehensive heart center is reasonable. The patient to benefit or will not benefit from this, and is the surgeon willing to do repair or not? In our rheumatic patients, it's very unlikely that we are going to be successful in doing the repair in these patients. So we are telling the patient from the start, we are going to replace your valve. Unlikely you are going to repair it, because the fibrosis prevent the surgeon from dealing with the valve. What does repair mean? Repair that you have a normal valve that is redundant or something like this, not fibrotic. So if you are fibrotic, you can take an incision in a fibrotic valve. When you take an incision in a fibrotic valve, it crashes the valve totally. Okay. Okay, now we have taken this is this was the base of our lecture, which is that we have to summarize what we said. We have you should have valve surgeries in a center that is well uh, well trained people work in it with multidisciplinary approach with people from cardiothoracic team and cardiac and infectious disease and nephrologist and intensivist and people from other departments because this patient is a high risk patient. This is what we said. Approaching the valve should evaluate the patient risk, the procedure risk, and the rehabilitation after this. You should consider different organs affection before sending the patient to valve. You should send any patient with valvular disease to a dentist before going to surgery. And now we are going to consider valve by valve what is the management of this one. Okay, the aortic stenosis. Stage of valvular aortic stenosis. Okay, as you know, stage A, as we said after mentioning the stage is at risk. Like the one with bicuspid aortic valve, is at risk of developing aortic stenosis. Aortic sclerosis is at risk. Okay, valve hemodynamics. Okay, when you see a Vmax below 2 meters with normal lifted motion. Okay, uh, the stage B is the progressive of mild to moderate calcification, fibrosis, bicuspid, trilift, or in the trilipid, or rheumatic heart disease changes with commissural fusion. And the Vmax here is from 2 to 2.9, and the moderate is from 3 to 3.9, and the mean and the gradient. Okay. Or you start to develop early diastolic dysfunction may be present, normal left ventricular ejection fraction. This is stage B. Because if you have affection in the left ventricular ejection fraction, you entered into stage C. Okay, stage C1, which is the asymptomatic severe aortic stenosis with severe calcification, fibrosis, congenital stenosis, or any cause, and the hemodynamic. This is you have a Vmax above 4, and you have aortic valve area typically below 1 centimeter, not required to define severe, but sometimes in this is important in patients with low body mass index. In low body mass index, sometimes you need to go below 1 to have 1 centimeter to consider this a severe aortic stenosis. I have seen old age females with aortic valve area 0.8, the patient is asymptomatic, his ventricle is normal, he has no problem. Especially in young old females with young with a small body mass index. They consider at that one the 0.6 is the cutoff point. Severe aortic stenosis with Vmax more than 5 or mean gradient is above 60. Okay, in asymptomatic severe aortic stenosis with LV dysfunction, you find also this in the valve, but you have the same problem, but the left ventricular ejection fraction is below 50. This patient should be dealt with. Okay. Stage D is the severe symptomatic aortic stenosis. Okay, they recalcified to D1 and D2 with the one with the high gradient aortic stenosis. The one D2 is the low flow, low gradient aortic stenosis with reduced ejection fraction, and this one, most probably the symptoms here is syncope, pre-syncope, heart failure, angina, and the heart failure is the predominant feature in these more than the other ones. Okay, this one you have to prove it that this has low flow, low gradient by doing something like the vitamin stress echo, which is very important in diagnosis these population. Okay. You have to consider the pulmonary hypertension in stage 4 of aortic stenosis because they have long-standing aortic stenosis. It should be evaluated thoroughly before sending those patients to surgery. Okay. D3, severe symptomatic aortic stenosis with the low gradient with normal ejection fraction or paradoxic at low flow severe aortic stenosis. Okay, this type, the D3, most probably they have heart failure, they have increased left ventricular relative wall thickness, small LV chamber with low stroke volume, with restrictive diastolic filling, and ejection fraction most probably is above 50, above 50. And the same regarding the valve area, and the patient is most probably normotensive. Okay, systolic blood pressure is low. Okay, الانيشال diagnosis بتاع الناس دول. اوكي، اول حاجه طبعا احنا عارفين الساينس بتاعه الاورتيك ستينوزس زي ما احنا متفقين. after we diagnose them clinical. لا، مش لازم يطلع فوق ال4 متر، مش لازم. دي 3 والدي 2. الدي 2 ده انت عندك لو فلو وعندك ريديوسد ايجكشن فراكشن، انت عندك الراجل ده عنده نورمال ايجكشن فراكشن. انا واحد عنده هاي جريدينت. ده هاي جريدينت، ده لو جريدينت. يعني انت عندك ثلاثه تباديل وتوافيق، جريدينت وايز، ايجكشن فراكشن وايز، هتركب الثلاثه على ما يطلع لك ثلاثه.
هو عنده ايجكشن فراكشن وعنده لو جريد، هو سيفير اورتيك اللي عامل كده.
It's indicated for surgery. هو ساعات sometimes انت بتقول لي طيب ما هو ده هل وهو عنده normal systolic function ان انا I leave him؟ لا، لان الراجل ده عنده، انت شايف ان هو عنده هنا هو normal systolic function بس عنده severe low flow gradient aortic stenosis. اوكي، كلاس 1 ايه طبعا ان العيانين دول لازم يتعمل لهم هيموداينامكس والميجرمنت بتاعتهم والليفت فنتريكولار سايز والستوليك فانكشن والترمينيشن اوف بروجنوزز والتايمينج اوف ذا فالف انترفنشن طبعا. اوكي، in patients with suspected low flow low gradient اللي انت بتتكلم عليهم والنورمال left ventricular ejection fraction اللي هو D3 optimization of blood pressure is recommended before measurement of aortic stenosis severity by transthoracic وcardiac. لازم الاول تظبط الضغط قبل ما تتاكد انك عشان تحكم عليه مظبوط. اوكي، in patients with suspected low flow low gradient اللي هم stage D2 low dose دوبيتامين، دول اللي احنا بنعمل لهم الدوبيتامين او بنعمل لهم invasive measurement عن طريق القسطره. اوكي، in patients with suspected low flow low gradient severe aortic stenosis with normal reduced اللي هو D2 او 3 calculation of the ratio of the outflow tract to the aortic velocity is reasonable. بس ده class 2A. اوكي، طيب in patients with suspected low flow low gradient severe aortic stenosis normal or reduced اللي هو 2 و 3 بنعمل لهم measurement of the aortic valve calcium score by CT. imaging is reasonable for further define of severity. وده important جدا جدا 2A هنا ليه؟ لأن most of these patients they already have corona. فأنت لما بتعمل calcium scoring كمان أنت بتبقى directed towards إن أنت غالبا هتعمل اللي عندك coronary angiography عشان تصلح الكورونرز مع ال أو I have never seen patients with severe aortic stenosis at old age with normal coronaries. Very unlikely. Very, very unlikely. And left main disease is very common, especially left main disease. In asymptomatic patients with severe aortic stenosis, stage C1 exercise testing is reasonable to assess physiological signs of exercise and to confirm the absence of symptoms. I have never seen anyone done this. Exercising severe aortic stenosis is not advisable. Dangerous. Okay? Especially exercise testing. You can do vitamin like an exercise, no. Very, very unlikely in act. Most probably these patients are old people. They can't exercise. In symptomatic patients with severe aortic stenosis, exercise testing shouldn't be performed because of high risk of severe hemodynamic compromise. I have seen only one patient who has done this with severe aortic stenosis and exercise, and he collapsed on the treadmill. So don't do it. Okay? Don't run any aortic stenosis unless you find congenital aortic. I have done this. I have done a stress test of congenital aortic stenosis in a person with 18 years old, and he did 18 minutes on the treadmill. So this is a different pathology. you have congenital aortic stenosis. He was very good built. He told me I go to the gym. So that what made me exercise. He told me I go to the treadmill 5 times a week. So I had no doubt that this person would have done it, and he did it. So he told me, should I do surgery? I told him I don't know. I don't know. You can run on the treadmill, but if you can run this, I don't know if you should go to somebody in the congenital department. In the medical therapy, is it important? Yes, but not as important as the mitral regurgitant people. In patients at risk of developing aortic stenosis and in patients with asymptomatic aortic stenosis, hypertension should be treated. That's very important according to standard GDMT, started at low dose and gradually titrate upward as needed with appropriate clinical monitoring. In all patients with calcific aortic stenosis, statin therapy is indicated for primary and second prevention of atherosclerosis on the basis of standard risk score. This is important, plus 1A, statin. Does it slow the progression of the disease? They say so. In patients who have undergone TAVI, ACE inhibitor RB may be considered to reduce the long-term risk of all-cause mortality. In patients with calcific aortic stenosis, stage B and C, statin therapy is not indicated for prevention of redynamic progression of aortic stenosis. The timing of intervention of aortic stenosis. In adults with severe high-gradient aortic stenosis, stage 1, D1, and symptoms of exertional dyspnea, heart failure, and angina syncope by history or by exercise testing, AV aortic valve replacement is indication. Okay. In asymptomatic patients with severe aortic stenosis, left ventricular ejection fraction, AVR is indicated, class 1. In asymptomatic patients with severe aortic stenosis, stage C1, who are undergoing cardiac surgery for another indication like coronaries, aortic valve replacement is indicated. Okay. In symptomatic patients with low flow regradient aortic stenosis with reduced ejection fraction, it is indicated, class 1. In symptomatic with low flow, low gradient, class D3, AVR is recommended if aortic stenosis is most likely the cause of the symptoms. Okay. In apparently asymptomatic patients with severe aortic stenosis, stage C1, and low surgical risk, aortic valve replacement is reasonable when an exercise test demonstrates decreased exercise tolerance normalized for age and sex, or a fall in the systolic blood pressure after 10 millimeter from baseline to peak exercise. Most probably you know that in exercise test the blood pressure goes higher. If it goes lower, then this is significant. In asymptomatic patients with severe aortic stenosis defined as an aortic velocity more than 5 meter and low surgical risk, aortic valve replacement is reasonable. In apparently asymptomatic patients with severe aortic stenosis, the C1 and low surgical risk, aortic valve replacement is reasonable when the BNP level is more than 3 times normal. That's very important advance in our practice. You do BNP in aortic stenosis to monitor the progression of the disease, the progression of the heart failure in this patient. If you are found that the BNP is rising rapidly, then this valve should be treated early. In asymptomatic patients with high gradient severe aortic stenosis, stage 1, low surgical risk, aortic valve replacement is reasonable when serial testing shows an increase in aortic velocity after 0.3 meter per second per year. This is an important figure. Now, بيزيد أكثر من 0.3 meter, you should treat this valve. To be back, in asymptomatic patients with severe high gradient aortic stenosis T1 and progressive decrease in LV on at least 3 serial imaging studies to less than 60, aortic may be considered. It should be. In patients with moderate aortic stenosis who are undergoing cardiac surgery for another indication, in moderate aortic, that's very important. I have seen patients who underwent CABG with moderate aortic stenosis without changing the valve, and they came 2 years later for aortic valve replacement. 2 years later. So when you have moderate aortic stenosis with coronary heart disease and you are going, you change the valve. You don't wait till it gets to be. timing of intervention. Okay. This is what we said in the في الفاتو، بس بشكل هنا الجوريزم هتقعدوا تراجعوها على الستيجز اللي فاتت هتلاقوها سهلة. It's easy يعني. Choice of intervention الحقيقة بقى mechanical versus bioprosthetic aortic valve. طبعا احنا بنميل طول عمرنا في العيانين الاورتيك فالف ريبليسمنت الى بايوبروثيسز اكتر منه ميكانيكال. ليه؟ لان اغلب العيانين دول بيبقوا ساينوتريزم، اغلب العيانين دول بيبقوا اولد ايج، اغلب العيانين دول بتبقى مش هتديله نواب فور لايف. فانت بتميل في الاورتيك بوزيشن انك تركب بايوبروثيسز. ليه؟ البايوبروثيسز دلوقتي عمره من 15 ل 20 سنه. فاذا كان جاي لك عيان عنده 65 years ومش هتديله وارفرين بوست اوبراتيفلي غير 3 months، فايتس better to do him bioprosthesis than to do him mechanical valve ونخش في البروبلمز بتاعت الوارفرين at old age. فدايما we go for this لحد ما طلع التافي. التافي طبعا خلى ناس كتيره to go for the تافي. طبعا الكلام الجديد كله بتاع السنه دي والسنه اللي فاتت على الانديكيشن اوف تافي اتس جيتنج لارجر، بالذات بعد ما هم ابتدوا يعملوا حاجات بقى تافي والكلام اللي بيعملوه دلوقتي، وعيان مركب 3 تافي يعني تافي حاجات كده يعني. ف now the indication انا مش هخش قوي في التافي والسيرجري لانه it's changing now. Most probably you will find it changing in the next few months لما يطلع guidelines كتير للفالفولار which will happen sooner، بالذات فيما يخص التافي لأنه it's going down in age which is not nice. لأن التافي العمر بتاعه still not long. يعني when you have a patient below the age of 60 and tells you I want تافي عمره 10 سنين ماكسيموم، فلما يجي لك بعد عنده 50 سنة يقول لك أنا عايز تافي. طب at the age of 60 will do valvular. صعب بقى لأنه طبعا doing surgery when you have such a prosthesis it's very difficult. فبيرجعوا بقى للتافه. دايما when you go for younger age it's better to go for valve replacement, especially the bioprosthesis one. The guidelines say in patients with aortic valve replacement, choice of prosthetic valve should be based on a shared decision-making process that accounts for the patient's values and preferences and includes discussions of the indications for the risk of anticoagulation and the potential need for and risk associated with valve intervention. You tell him the potential, what will happen in the future. For patients at any age requiring aortic valve whom VKA is contraindicated or cannot be managed appropriately or is not desired, a bioprosthetic is indicated, class 1. For patients below the age of 50 who don't have a contraindication to anticoagulation and require aortic valve replacement, it is reasonable to choose a mechanical valve prosthesis over a bioprosthetic one. الصغيرين you have to put them there. سلامك. For patients 50 to 65 years of age who require TAVR, aortic valve replacement, and who don't have a contraindication to anticoagulation, the 50 to 65, it's reasonable to individualize the choice, either a mechanical or bioprosthetic, with consideration of individual patient factors and after informed shared decision. هم حطوا بقى الحته بتاعت من 50 ل 65 نقعد ونتكلم معاه ونشوف هو عايز ايه. If patients أكثر من 65 years of age or require aortic, it is reasonable to choose a bioprosthetic أكثر من 65. فأقل من 50 who prefer a bioprosthetic and have appropriate anatomy replacement of the aortic by a pulmonic autograft, the Ross procedure may be considered as a comprehensive valve center. دي حاجة مرتبطة بالجراح لأن Ross is a very big procedure. دكتور مجدي يعقوب one of the انتوا عارفين هو متعلم من دونالد روس، يعني البروفيسور بتاع مجدي يعقوب هو دونالد روس، فهو اتعلم منه الروس بروسيدور وهو عمل لها موديفيكيشنز في الروس بروسيدور، فهو تقريبا اشهر واحد في العالم بيعمل الروس اوبريشن دي بعد ما عمل لها موديفيكيشن. ف الروس طبعا مش اي سنتر بيعرف يعمل روس، ومش اي حد مش اي جراح بيعرف يعمل روس لان ليها سبيشال تكنيكس كده. هم بيشيلوا البلمونري فالف ويحطوه مكان الاورتيك. For the symptomatic and the asymptomatic patients with severe aortic stenosis, any indication for aortic who are أقل من 65 of the life expectancy أكثر من 20 years الحقيقة ده لازم يعمل جراحة، ما يعملش تافي. حتى هذه اللحظة ده كلاس 1 for symptomatic patients with severe aortic who are من 65 ل 80 and have no anatomic contraindication to TAVI أو ده or transfemoral ده recommend after shared decision making. هنقعد بقى نتكلم معاه ونقول له تعمل كذا ولا كذا. or symptomatic patients with severe aortic stenosis أكتر من 80 or the younger with life expectancy الله ده ما تعملوش جراح، ده اعمل له transfemoral TAVI as treatment of choice اللي فوق ال 80. اوكي in asymptomatic وسيفير aortic والايجكشن fraction اقل من 50 واقل من 80 and have no anatomic contraindication لتافي the decision between TAVI should follow the same recommendation as for symptomatic اللي هي recommendation تقعد تتكلم مع الراجل وتتفق معاه. or asymptomatic بس طبعا في حته بقى فاينانشال هنا بتخش في القصه ده. طبعا هم ما عندهمش الحته الفاينانشال. ليه؟ لانه غالبا في the western countries the cardiac surgery is much expensive than the TAVI. لانه عندهم الهوسبيتال ستاي بتاع ال5 ايام اللي بعد العمليه ده is very expensive. فلما تيجي تبص على الباكج كلها على بعض هتلاقي انه الاورتيك valve replacement surgical wise in the United States costs around $50,000 while TAVI costs around $30,000. So they are in favor of TAVI from the cost benefit effect. العكس هنا انت عندك الاورتيك فالف ريبليسمنت بص لو انت بتحسبها في مكان برايفت يعني يتكلف 250,000 في حين التابع يتكلف above 1 مليون. ففي هنا هو عنده مش حاطط الكوست بنفيت في القصه لانه هو عنده الكوست ميال للتافي عننا. احنا عندنا العكس صحيح. For asymptomatic patients with severe aortic stenosis and abnormal exercise test very severe aortic stenosis rapid progression, this is preference of TAVI. Sorry, surgery أكتر من TAVI. For patients with indication for aortic valve replacement, bioprosthetic valve is preferred, but valve or vascular anatomy or other factors are not suitable for transformer TAVI. يبقى هنا for SAVR هو indication. For patients at any age with severe aortic stenosis and high or prohibitive surgical risk, TAVI is recommended. ده واحد بقى مش هيعرف يكون عنده بقى ليفر سيروز، ده مش هيخش مش هيتخطر، ده يخش يعمل بغض النظر عن الايدج. For symptomatic patients with severe aortic stenosis whom predicted post-TAVI or post-surgical is أقل من 12 months whom minimal improvement in quality of life is expected, palliative care is recommended after sales decision making including discussion of patient preferences and values. نقول له احنا مش هنعمل لك حاجة مش هنيجي لو هو أصلا life expectancy أقل من 1 year. In critically ill patients with severe aortic stenosis percutaneous aortic balloon dilatation may be considered as a bridge for TAVI or SAVR. ده أنا شفت الحالات دي حالتين قبل كده كانوا critical ill واتعمل لهم بالون dilatation. هو عيبه إنه بيريكير. أمال ليه ما بنعملش بالون dilatation زي البالون mitral؟ لأنه غالبا ده بيبقى calcific valve يا إما ما بتديش good result أو بيحصل recurrence غير البالون mitral. It's fibrotic not calcific الميترال. مش كده في العيانين بتوع السيفير mitral stenosis calcific ما بنعمل لهمش ده كونتر انديكيشن فور بالون. ليه بقى؟ لأنه الانوي بالون is a very big balloon when you use it in the mitral position it cuts the valve فبيحصل لهم acute mitral regurgitation في calcified valves. فعشان كده منعوها انها تحصل and acute mitral regurgitation sometimes cause death. فلو عملوا الويلكن سكور عشان تحدد بيه ان العيان ده is calcified so he can go for it's not advisable to go for balloon. اوكي ده الشويس كل اللي قلناهم هيجوا بقى في القصه دي بقى. دي شرح للفرق بين البايوبروتيسيس وده وامتى هندي القصه دي. طيب دي تلخيصا للي فات ان احنا امتى هناخد تافي وامتى هناخد سيرجيكال ريبليسمنت برضو تلخيصا لكل اللي فات. انا هكتفي بهذا القدر فيما يخص الفالفولار هارت ديزيز، ان احنا خدنا البيز لاين بتاع الكاردياك سنتر وخدنا الاورتيك ستينوزس. هناخد بعد كده in different sessions الحاجات التانية، لأن أكتر من كده it will be too much. نكملهم in another session. حد عايز يسأل حاجة على القصة دي؟ هو الأمريكان زي ما أنتم شايفين it's very easy والslides are very well done، فاللي عايز يذاكر حتى منها it's easy to study from them، أسهل حتى من التكست نفسه في مذاكرة القصة. Sinus aneurysm with dilated left atrium and severe mitral stenosis. أو في سيفير كمان mitral stenosis. أنت رايحة للبورد ولا أنا رايح بقى للسيفير mitral stenosis. I anticoagulate. I myself, it's not in the guidelines, but most of our professors they anticoagulate this type because we have seen ودي أنا شفتها كذا مرة بعيني patient with sinus rhythm and stroke and severe mitral stenosis. I've seen it in young females, young males. في عيان من أيام نيابتي ما انساهوش عمري، كان عنده 27 years old severe mitral stenosis. He came with massive stroke and he's in sinus وقعد معانا in sinus for a while. هو اللي أنت بتقوله ده في ال unexplained stroke، يعني أنت بتتكلم على واحد old age عنده ستروك احنا مش عارفين جات له من ايه، فبنعمل prolonged holter for 1 week عشان نشوف العيان ده بيجي له ايتر فابريشن ولا لا. لكن انت عندك عيان mitral stenosis وستروك وعنده 25 سنه عنده severe mitral stenosis. If you think about anything other than the mitral stenosis and the embolization، ايه ده؟